All right, it looks like it is 9 o'clock, so we will get started. Good morning, everyone, and thank you for participating in our 5th Stakeholder Sharing Session, and this one is focused on oral health policy. Again, for those who have joined our last sessions, this is all repeated. But before we get started, I wanted to just cover some ground rules and logistics for today's session. So currently, a majority of you are on this session right now as participants. However, once I'm done talking, I will be switching over everyone to be a panelist so that we can all see and hear each other. If you're only joined on phone and we can't see you, if you would take a moment now to just come off of mute so that we know that you're here and can put a name to your number. So if you could just take a minute now to do that. All right, so hearing none. Once everyone does become a panelist, just note that if we hear a lot of background noise, we will mute you, but you can unmute yourself at any time to contribute. So you can do this by hitting the unmute button. It's in the bottom left-hand corner of your Zoom screen, and it looks like a little microphone. Also, if you just want to temporarily unmute yourself, you can press and hold the space bar on your keyboard. Once we switch you over, you also have the option to enable gallery view so that you can see the most people at once. To do this, you're going to go to the upper right-hand corner of your Zoom screen. It'll either say gallery view or speaker view, so you can choose between those options. If you are having trouble doing this or your Zoom screen is set up differently, you can always look back to the confirmation email and the reminder email that Zoom sent, and there's some helpful links and tips at the bottom of that email. So as you may have already seen, if you are able to see the screen, we are using the chat box to introduce ourselves. So if you haven't already, please type in your name and organization so that we all know who's here. Another great way for us to put names with faces is to rename yourself. So you can do this by hovering over where your video or your name appears on the screen and right-clicking. And there you can just click rename. Or if you hover over, there's also 3 dots that appear in the upper right-hand corner of your little video, and you can click on that to rename as well. So lastly, we just want to do our best this morning to stay on topic and keep our conversation relevant to oral health policy. So we are all on this call and we are ready to participate. So with that, I will pass it over to Helen.
All right, thank you so much, Amy, and welcome everyone. I'm Helen Hockey, Executive Director for the Pennsylvania Coalition for Oral Health, and I second Amy's welcome, and we are so glad you are here. These sharing sessions were an idea where we've really struggled to figure out how we could connect and get our stakeholders together during this time of social distancing. And so this has been one way that we're trying to be able to continue our connections, and we appreciate everybody coming and taking the time to participate. A lot of you have participated in more than one session, so we really very much do appreciate that. And I would encourage you, the format for today is I'm going to speak for a few minutes on some of PCOH's work around oral health policy, and then we have a handful of folks that we've invited to share some information, and then we're really going to open it up, and we would love for everybody to, really feel like you can fully participate in the conversation. Feel free to share your video, and make sure, if you have questions, even if you don't want to come off of mute, you can always type them into the chat box or the Q&A box, and we can use those to address any concerns that you might have. So definitely feel free to participate as much as you would like. So, on to the topic at hand, oral health policy. I'm going to give just a few minutes of background for those who might be newer to PCOH and sort of maybe aren't as familiar with our work. We are the statewide Oral Health Coalition for Pennsylvania. We're part of a national network of around 40 states that have oral health coalitions. And our coalition is really meant to improve oral health for our residents. We don't represent any specific provider type or insurance or anything like that. We're just sort of a compilation of all of those things rolled into the greater good of improving oral health. So we work at a lot of different levels. We do work locally in some instances, as well as, you know, all the way up to the national level for some of the different groups and work groups that we sit on and serve on. We are a nonprofit, so we rely on a lot of donations and grants to fund our work. And we're super grateful for all of those who have contributed or help us do the work that we're funded to do. And so, you know, one of the other things I always like to point out when I'm talking about what the coalition does is that we're stronger as we learn more and more about what's happening in the state. So, you know, one of the best things that we're able to do is make connections with groups that maybe don't know the other exists. So, you know, if something's happening in the southeast corner of the state, somebody in the northwest might have an idea and want to do something similar. And we really find that that's one of the best things that we can do is make those connections so that people can share work and initiatives and ideas. So that being said, our coalition focuses on 4 main priorities. We look at oral workforce, which of course is inclusive of more than just, you know, dentists, hygienists, assistants, dental staff. It also focuses on oral health being provided, oral health services and education being provided by many groups. So, you know, we may look at pediatricians offering services, you know, or community health workers connecting their community members to care. Those could all be sort of examples of oral workforce. We advocate for community water fluoridation, which is, of course, something that we struggle with in Pennsylvania. We are a little bit behind the curve, I would say, when looking at the goals that we've set nationally. So community water fluoridation is something that we'd like to see more Pennsylvanians have access to in the future. And then we look at specifically improving oral health for our more vulnerable populations. So whether that is, you know, a group that is vulnerable because of anything from income level to racial or ethnic minority status to, you know, documentation status. There's a lot of different reasons that folks would be considered underserved or more vulnerable. So, you know, in the spirit of health equity, trying to get more care for those groups and to really level that playing field. And then lastly, what we're going to really be talking more about today is how we can implement oral health policy into all systems. So we'll give you a couple examples of some of the work that we're doing. And I hope that that's helpful for, you know, either thinking of ways that we could collaborate with you and your work, or maybe generating some new ideas for things that you might want to consider working on. If you are new to PCOH and you don't know as much about some of our past programs, we invite you to check out our YouTube channel, which has a ton of videos and information about the work we've done over the last few years. So that being said, as we look at the areas of policy work, I just have 3 slides, I swear, and promise just to sort of touch on things. But if there are things that you have further questions about, you know, then we'll have a lot of time for open discussion at the end. But I want to give everybody sort of a high-level view of some of our main areas of focus. So starting more on I would say the more common things we think about when we think about health and healthcare. We are part of a few different groups, and I just named a few here so that the attendees could get a little bit of a broader knowledge for some of the groups that we work with. But our state health Healthcare and Hospital Association, HAP, it's called, runs a Pennsylvania Provider Advocacy Coalition. And that group is something that PCOH has been involved with for about the last 2 years. And what they do is they really advocate both at the state and federal level for protecting healthcare providers. So right now we just submitted letters asking for specific funds to be directed towards all healthcare providers. Many are struggling right now from a financial and economic standpoint. So we want to make sure that as funds come into the state, that we're being mindful, particularly for small and private practices. So when we look at dentistry, that's a really big deal right now. We know that a lot of the dental offices are struggling with having their doors closed or mostly closed for the last few months. The Coalition for the Common Health is another group that was formed just a little over 2 years ago, and they really focus on the leadership from behavioral and physical health care to sort of promote what we would call whole person primary care in Pennsylvania. So that group meets quarterly, I believe, and we get together and try to figure out ways to promote healthcare in general, sort of as a basic human function. And then, of course, I mentioned the Pennsylvania Cancer Coalition here as well. Obviously, many chronic and infectious diseases have work groups and coalitions. The PA Cancer Coalition is one of the bigger ones, so I just wanted to sort of mention that. They have an HPV work group, so human papillomavirus, that looks at the incidence of cancer from HPV. And then inside that, there's even a dental subgroup. So if that's something that interests you or you would want to learn more about that, please feel free to reach out and we'd be happy to connect you. So when we look at that and we think about policy, where we would go with that is there has been interest in the last, we'll say, year or so around how we could improve things by getting dentists to provide HPV vaccines in the office. So that could be one area of policy that we could pursue working with the Cancer Coalition. Next on the list there is school health. That's something that we hear a lot about from our stakeholders, concerns about obviously all the things listed there. So we know that our state has a mandated dental screening program. You know, we're looking at ways to improve that always. And, you know, one of the ways that we could do that is using our certified school dental hygienists. You know, those are hygienists that can work directly in the schools as employees of the school district. And we know that that provides services and education directly to the kids right in their schools, which is a great place to do it. School-based health centers is another option that we've been pursuing and looking at. Our state actually has a much lower percentage of school-based health centers to population as compared to other large states. So we've only got, we're waiting on the most recent data, but somewhere in the neck of the woods of 35 to 45 school-based health centers in the state. And when we're talking about 500 different school districts, we know that that's not a real high percentage. And those would be centers that could offer physical and dental care to students and the community right at the school. And then lastly, we watch for things around school sealant programs, ways that we can improve policy for that and add those school sealant programs into schools. Because we know that as a public health measure, school sealant programs are successful. Children's health, wanted to touch just for a few minutes. I know some of you are familiar with PCCY's Dream Care Coalition, what that focuses on. And you'll see there's some highlights, highlighted links on these documents. We'll be sending these slides out. So when you get the slides, you'll be able to click right on the links and go to the sites if you want to find out more information. But the Dream Care Coalition is a group we've been involved with for a bit here. They've got about 100 organizations across the state that are focusing on providing health care and health insurance to all children. We've got about 24,000 in our state that have no access to healthcare services based on their immigration status. So that leads to bigger issues for emergency care and costs. And that group primarily focuses on advocating for all children to have access to health insurance. So I think that's a great group to get involved with if it's something that fits with your mission. And then CHIP coverage, we look at right now, our CHIP coverage for dental is great, but we would love to see, you know, more, basically stronger dental services and dental advocacy in CHIP. A lot of times dental gets sort of pushed aside as part of the larger, you know, sort of in contrast where, you know, physical health might take over probably a little more than it should, and we'd like to see dental be kind of elevated within CHIP as well. And then lastly, looking at medical assistance providers, particularly for children, we still see a lot of issues in our state where a lot of dentists are not necessarily credentialed as medical assistance providers. So general dentists in our state are only about 23% of them are. And so when kids go to find a dental home, you know, there are a lot of areas of our state where, you know, the kids are waiting 3 to 4 months for just an initial appointment. So that's something that we focus on specifically from a policy standpoint as well. Couple other things that we've been working with, medical dental integration, of course, is sort of a buzzword right now. Well, has been for probably the last 10 or 15 years, but, you know, really truly adding dental services to medical offices is a pretty important thing. And PCOH is really supportive of any policy that would help do that. Some of that ties directly with teledentistry. It's been interesting through the COVID pandemic that we've seen, you know, some loosening of rules around teledentistry, and we've seen a lot of offices starting to use it more and more frequently, including our health centers in the state. So we are hopeful that we will see that trend continue to increase access. Our state doesn't specifically have a policy against teledentistry, but it's not necessarily something that's mandated to be paid for. So we do follow all of the teledentistry bills in the General Assembly very closely in telemedicine. The State Board of Dentistry, obviously part of our role is to track all the pending changes to dental regs that apply to workforce and, you know, support those with testimony and letters. It's something that we sort of keep an eye on and track. Hand in hand with that, when we look at insurances and health plans, many of you are probably aware that our state is moving to from a federal platform. For this year, we've moved to a state-based exchange on a federal platform. And then we will make a full conversion to a state-based exchange in about a year. So what that means is that folks who seek to get insurance through the ACA on the federal marketplace will now be able to do that through a Pennsylvania marketplace. So we've been serving on the outreach and education work group of the Health Insurance Exchange Authority so that we can sort of offer guidance on to making sure that the proper messaging is getting out there and including oral health as much as we can. Billing and coding, I just wanted to mention, you know, some of the policy things that we advocate for. Many of you have heard that tobacco cessation counseling is now covered by Medicaid insurances. You know, so we watch things that we can and should add to the fee schedule, and we like to support things like that. So right now we've been trying to, you know, talk to different individuals and insurance companies about how we can add things like silver diamine fluoride for adults, particularly during the pandemic, so that, you know, for adults who can't have access to get a filling right now, they may be able to get a treatment like silver diamine fluoride to arrest that disease. So those are all things that we sort of work with the managed care organizations on and advocate for. Federal policy, we do work with some federal partners to, you know, on a lot of different issues. One of the things we've looked at is our state is fortunate enough to have a CDC oral health grant for the next few years, but we would love to see a little bit of increased funding on a federal level for that program so that all 50 states can have a grant, because it's been a competitive thing for many years, and it ends up sort of giving some states the benefit and not all. So we do advocate for increased funding from the CDC for state oral health grants, as well as adding dental coverage to Medicare. I'm sure many of you are aware that basic Medicare plans have no dental coverage included. And that's something that, we've gone to DC and talked with legislators about, that dental coverage in Medicare is really, really important. Local policy, we do a lot of work. I mentioned our work around community water fluoridation. So what that means is that when communities have what we would call threatened rollbacks, where a community that has the benefit of optimally fluoridated water might have a challenge to that. We do have a team that we activate and do advocacy at the local level for retaining and initiating community water fluoridation. And then we look at the state level. We advocate for increased funding and infrastructure for the state oral health program that exists within the Department of Health. So we're fortunate that we have a handful of federal grants from CDC and HRSA that help fund our oral health program, and we would like to see that evolve even more so over the next few years. And the last sort of smaller area of policy work that I just wanted to mention is looking at health information technology. So, we know that many medical offices have moved to electronic health records, but dentists have sort of been a little bit behind in that. And so, looking at how we can integrate electronic health records with electronic dental records and promote offices to communicate and use electronic dental records, which also means we have to watch broadband access because many of our rural dental clinics don't have access to broadband, which makes it very difficult to have an electronic dental record. So, that's something else that we do tend to talk to policymakers about is, sort of addressing that digital divide between rural and urban, because we know that a higher percentage of rural areas do not have the access that urban areas do. So that's a really sort of a big deal for us. And then last thing I'm going to talk about is I just wanted to, of course, mention one of our biggest projects, which is focusing on Medicaid in our state so that we can make some changes to our current Medicaid program. We've got, around 1 million adults that are enrolled in the state Medicaid program. And there's a few different pieces here that we try to leverage. And I know I've invited Vanessa to talk a little bit about this when I'm finished up, but I did want to just touch on it, that, there's a handful of things around it. We'd like to extend postpartum benefits. Right now, moms, after they have babies, are covered for their dental for about 6 weeks postpartum. We'd love to see that extended to a year. And there are some other groups that are working on that. So we've partnered with those groups as well. What that would do is sort of keep mom connected to a dental home up until the time that her child would be needing a dental home. And I think that that's a really important thing in terms of multi-generational family care. We look at the benefit limit exception under Medicaid, which is the exception process that was designed in 2011, so that for services that aren't covered, patients who have a, we'll say, dire medical need to have those dental services can apply for a benefit limit exception. So we would love to see that program just made a little more consumer friendly, and there have been some changes made, which, if anyone would want to know a little bit more about, we could obviously share some of those details. And then I mentioned the changes back in 2011. Our comprehensive dental benefits were cut for adults in 2011. And I think probably most of you on the call are very aware of that. And so we would love to see those comprehensive benefits restored. And I know Vanessa will talk a little bit about what we've been doing around that. We do run an advocacy work group around the Medicaid issues, and we meet monthly. So anybody who's interested in sort of joining in or even listening in on those calls is more than welcome to. We've got maybe a dozen organizations or so across the state that work together on that. And then, looking at sort of, that's a multifaceted kind of work group. We're doing some legislative efforts, doing some correspondence with the General Assembly, as well as doing community education. So the more we can get the general public behind having comprehensive benefits is a really good thing. I did want to mention, it's just come up, I know the state budget, I think it passed the House yesterday. They're doing a temporary 5-month budget is sort of the plan at this point, that will just flatline everything until November, and then they'll do a 7-month budget in November. So we sort of have, one of the things we were kind of disappointed about was, if a year-long budget was determined now, chances of adding things in like comprehensive dental benefits probably wouldn't have a chance. And we understand that, the why behind that, of course. But now it looks like if things go through and pass like they're expecting, that, there'll be another opportunity in November to maybe address things, maybe more in a recovery phase. So that's something that our work group's going to have to be looking very closely at, is ways that we can reduce overall health costs by increasing, preventive and education services for everyone. So with that being said, I just wanted to, that's really about all I had from PCOH's perspective, just sort of a high level look at some of the things that we work on a day-to-day basis. And I did want to invite Vanessa to just speak for a few minutes on a little bit more around our adult Medicaid work, because we've made some progress in the last 6 months or so that we're proud of. So, Vanessa?
She gave me a strict time limit, so I'm going to stick to it. A couple of things that I wanted to mention, and I'm not sure if Helen mentioned it or if she's being modest. One of the things that Disability Healthcare Initiative has been working on with PCOH is that we've sent letters to Congress asking for an FMAP increase of 12%. Sorry, Helen, I can recall if you mentioned this. An FMAP increase of 12%, specifically with 5% carved out to cover costs for oral health. So we were working on getting that in some of the COVID relief that's been going out. That letter, I believe, has already been sent to members of Congress, and we've been contacting our own personal members of Congress to try to increase, get some kind of FMAP carve out for oral health. Another couple of things that we've been working on, because Disability Healthcare Initiative, I was telling Helen the other day, I really do actually get angry and tearful parents who call me because they really can't find dental care for their children who are experiencing disabilities. And Helen sent me something the other day that was a pretty stark illustration of just how dire that need is. So anyone on the call, I know that many of you are also working on this issue, and we appreciate that. Anyone who would like to get more involved, that's super. We have a webinar going out to encourage dentists to dental professionals to accept more patients with disabilities. We do work on BLE streamlining and making that more accessible with PCOH, as well as we have been starting to talk. Nancy Murray is on the MAC, and I know that they're starting to kind of bring up raising the provider reimbursement rate. We think that that's really important to keep dentists in the game after this all happens. Aside from increasing access, we also have HR 799, which is our really big project, which is in the House right now. It's in the House Health Committee. basically HR 799. It simply asks the Commonwealth to give us the data so we can share it with an analytics team who has offered an in-kind donation. They're going to do all the analytics for us for free. And we just need to get the data from the state to see whether the cuts in 2011 are costing us more than we thought that they would. So did they just shift costs elsewhere? And that's what HR 799 does. It simply authorizes the Commonwealth to share the data with our analytics team, and they're going to look at that and see if there are more cost-effective ways that we could be providing better care to Pennsylvanians. We have a meeting coming up with a senator who has been supportive of oral health work in the past on Thursday to talk about 799 in the Senate. And that's kind of where we are with that. So 799 was really kind of rolling along until all of this happened. It all came right to a screeching halt, right? Before our advocacy day. But we're still working on HR 799 and hoping to put that through.
Thank you, Vanessa. That was awesome.
Was I in my time limit?
You were succinct. I love it. Yeah.
Okay.
Now, if I could follow time limits that well, we'd probably be doing better. And then I also, we can sort of bring this back up for conversation, but I also wanted to invite Dr. Harry Goodman, who is a dental consultant under our HRSA grant with Pennsylvania, who has been sort of helping guide high-level oral health programming in our state, because he's got a lot of experience in doing that work. So I wanted Harry just to sort of give a high-level overview of sort of what oral health programming can mean for policy in a state, and his experience in Maryland can kind of guide that. So Dr. Goodman, I'll turn it over to you.
Thanks, Helen. Can you hear me? First of all, I never had to deal with an issue like COVID. I always tell that to Dr. M all the time to reassure her she's been sort of thrown in the deep end of the pool. State oral health, a little bit of my background, I'm now retired, but I was the Maryland State Dental Director at the time when Diamante Driver passed away, and that we dealt with that, which was a huge policy, pretty much a policy initiative, basically, both, as I used to like to say, capital P and small p policies, basically. State oral health programs, I think, are important to a state. I think that those states that do not have strong state oral health programs probably don't do as well in terms of dealing with oral health issues in the state. I think they're necessary. I don't think they're sufficient. I think there's a lot that has to go along with it. And I think the most important aspect to a state oral health program is having a strong coalition to partner with, because a coalition can do things that a state oral health program cannot. Ironically, the three pillars of public health are assessment, and, collecting data and what have you, and then it's assurance, which is making sure that the public is taken care of, whether it be through community water fluoridation or evidence-based sealant programs or what have you. And the third one, and the irony is, it's policy development. But yet a state oral health program and policy is huge, but a state oral health program cannot advocate. It can only inform. So even on an issue as basic to all of us as community water fluoridation, you cannot go out there and absolutely say, vote for community water fluoridation. All you can do is provide the information that'll help others make that decision. But that's where a coalition is really, really important, because it's the coalition that can do that advocacy. And behind the scenes, you get sneaky and you work with your coalition director to do things that I basically couldn't do. But I once actually crossed the line on water fluoridation. I actually got hauled before the Inspector General in Maryland because somebody against fluoride thought I went a little bit too far, and he just kind of, it was nice that I knew the person, and personal relationships within the health departments are critical, but it can get that crazy. I think the important thing about state oral health programs is that there really are the principal state health department organizational unit that deals with oral health. There used to be a saying, what about dental? It was people used to wear little buttons and what have you about it. And I can just assure you that if there is no strong dental program, in fact, if there's not a strong dental director at all, no one is going to be addressing oral health at the state health department. You feel like you're the little engine that could by trying to get stuff done, but they deal with so many issues that if there's nobody at the policy table to say, what about dental, nobody is going to address it, basically. So that's pretty much what the importance. And so it's having access to a state health officer that really can make it or break it for oral health. And my little thesis for Pennsylvania is that up until now Jan Miller and Dr. Mazafarian are doing a really great job. And of course, a wonderful partnership with PCOH and all the partners, because I think partnerships in Pennsylvania is your strength by far. But I think in the past, there has never been a very strong oral health program. And I think that's why up until the last maybe 5-10 years, you've been behind the 8 ball in Pennsylvania, like we were in Maryland too. We had a very strong, very small program. And then with the, unfortunately, not the way to have an opportunity, but with the passing of Diamante Driver, it just changed the landscape completely. And the importance about that is that we always had a shovel-ready policy plan in place. So when that opportunity presented itself, we were able to run with it, and we went into many different directions. But basically, what the state oral health program really is responsible for assessment, for tracking disease rates. It certainly is there to create and advocate for evidence-based prevention, community prevention programs. And that, of course, helps, as Helen mentioned earlier, about getting funding from federal agencies like CDC and HRSA, where you can actually then direct the federal guidelines basically on these programs to make sure that the local programs do what they're supposed to do and do it in a way that's both ethical and evidence-based, providing expertise and training and technical assistance in various areas. And we deal with a whole slew of issues. I mean, I used to feel like I was a juggler on certain days because it was just how many balls in the air do I work on? But it ranges from fluorides to school health and school and adolescent oral health issues, perinatal, early childhood disease, chronic disease, and that's just the dental part. And the beauty about a state oral health program is that you have access not just to your health officer, but to all your chronic disease programs, cancer prevention, tobacco prevention, chronic disease. So you're able to, with doing it smartly, being able to partner with people on leaders in those areas on various issues, whether it be hypertension, whether it be diabetes prevention, whether it be tobacco. And of course, there's a lot of crossover there. Certainly oral cancer. And of course, what's going on right now with, with oral pharyngeal cancer and HPV, which is a great area to explore. And I think that's what Helen was talking about, eventually maybe even to the point where dental offices are doing the vaccines themselves, because who better to give shots than dentists and dental hygienists, for God's sakes. So those are kind of the issues, special needs, healthy aging, just a whole slew of issues. And obviously promoting access to dental care. And that was, of course, the whole issue that we dealt with Diamante Driver, because we were at one point ranked by the ADA as the worst state in the country for access to care. And by the time we were done with all our policy initiatives, and it ranged a whole slew of things, I'll be happy to answer questions later if you want, ask about that. We actually received an A from Pew Foundation on access to care, because we were able to address every issue in a way that kind of worked together, basically, whether it be oral health literacy, whether it be, it's all part and parcel of access. Access is a very simple term, but there's so many elements that go into meaningful access to care. And that means having a knowledgeable public, having providers that are well educated. I mean, there's just so many issues that I can go into, but I won't at this point. And certainly, I think what state oral health programs do, as do coalitions, is really we're conveners. We're great. We like to partner. Partnering is absolutely key, and that's why I have such faith in what's going to happen in Pennsylvania. I've been always talking about how it's amazing. When I first got involved, I'll be very brief about in Pennsylvania as a Head Start oral health consultant in Philadelphia. I did that in addition to being the state dental director in Maryland. And there was just nothing going on at that time in Pennsylvania. Really, this is way before the coalition, and I met some of you, I'm sure, know Amy Requa, and Amy and I started working together, and we met other people, and it's just amazing what you've been able to accomplish in the last bunch of years. And I've had all the faith in the world with a strong coalition and with an increasingly stronger state oral health program under Jan Miller and Dr. Mazzafarian. I have all the confidence that you're going to continue to achieve great things despite this current halt in progress with COVID, which is, as I said earlier, something I never had to deal with ever, and it's taxing on any state oral health program. So partnerships is everything, and I think that my son right now is looking at me, laughing at me as I'm home doing this right now. But anyway, I think that's the key, and I think with a stronger program, hopefully continued funding from CDC and HRSA for everybody, PCOH and the state oral health program, I think you're on to doing some great things. And I'll stop there, Helen. I probably went over my time limit, as I usually do.
No, you're perfect.
But thanks.
Dr. Goodman is such a wealth of knowledge for us, and we are so fortunate. I actually always joke when I talk to the Maryland Coalition, and I say, we have him. He's with us now.
They think I'm a traitor.
Yeah. Well, it's okay. We'll take you. So, and I think the other thing that's just, and I don't think Dr. Goodman mentioned it, but, just in light of our state oral health program, up until a few years back was, a one full-time person program. And so we've been fortunate to add some roles in that in the last 2 to 3 years. So now I think we're at 3.2 full-time employees in our oral health program. But Dr. Goodman, what's Maryland at in their state oral health program?
We have
approximately
about 15 full-time employees.
Yes. So that's, I think that's just paints a really broad picture of where we need to get to if we want to elevate oral health across policy and structure in our state. And
it's not just a number, it's just who they are. Again, our first CDC grant helped to define this. So we have an epidemiologist, an evaluation specialist, we have a school ceiling coordinator, specific roles that played, together basically to provide a functioning unit. And we were still relatively small compared to the chronic disease programs and tobacco prevention programs I mentioned earlier. I mean, but as a state program, I think we became one of the larger ones. Again, through the death of a child, we built a program, and that's not the way to do it. But I do say, always have a shovel-ready plan in place when the time, presents itself, basically.
Yeah.
So.
Thank you. Any questions specifically around that side of things? I know we've thrown a lot at everybody, and even going back to some of the other work, if anyone has any questions more so to just learn a little bit more about some of the work we've been doing around sort of any of the topics that were mentioned.
Well, I don't have I don't have a question, but I would like to make a comment if I could.
Of course.
You wouldn't stop me. You never stop me, Helen. Thank you very much. And I'm really glad to meet Dr. Goodman. I don't think I've actually met him in person. I look forward to maybe doing that someday, because I would like to learn about what you did in Maryland and learn from that. So there's a condition that affects oral health, and it's kind of new to dentistry. It isn't really, but our ability to diagnose it, recognize it, and treat it is kind of new, and that's oral sleep apnea. You know that both adults and children have problems sleeping and snoring as a result of some of tissue growths in their tonsillar tissues and large tongues. And that can really be a tremendous problem for a youngster who doesn't sleep and then falls asleep in class, and so gets hurt that way academically. They can't compete in sports as well, and so on and so on. And I don't believe right now in Pennsylvania we're doing anything to screen children for that as part of oral health. I think it is part of oral health. I think a screening can be simply composed. And actually, I have one that I'd like to show you. If Helen would allow me to screen share, I can show you a screen that we've added to our electronic oral health screening program that does just that. So
you should have that ability, Dr. Greenberg, I believe, if I have technology correct here.
Let me see if I can do that.
We've all become sort of IT experts, I think, through COVID. That's one bright spot is I think everyone's comfortable.
It says that you've disabled screen sharing.
Amy will fix that.
Amy, can you enable me?
Yeah, it's interesting because I'm only joined as a panelist just like everybody else. So I know you guys were seeing my screen, so.
No, it still says host disabled. Are you working on it, Amy?
Yeah, she's got it.
Tell me when I can try it. Hello,
Okay.
Amy.
Try it now, because I clicked the button. I don't know if it'll.
You got it. You got it.
Woo!
Okay, so let me see if this will work. There it is. So what you're looking at is one screen of a series. I'll just go back to show you, here's one on orthodontics. And so we can make, as you see, a choice here. And then we go on to the next screen. And so this is about oral sleep apnea. The column on the left is the Brodsky Friedman classification, where you're looking at tonsils. And you don't need to be a genius to look at a child's mouth. This can be done in a screening environment, could be in a school, in a daycare, and make a determination from 0 to 4. And then the right-hand side is the Malampati classification, which has to do with how the tongue, the rear of the tongue, can close off the airway. And so very quickly, I could say this child is maybe a 2 and a 2 over here, and then go on to the next screen. And at the end of the program, this gets uploaded. And so that child has this as part of their record. What does this do for the child? I believe that treatment of these conditions is best when diagnosed early. When we're adults and we're snoring and we have these conditions, it's much, much tougher to try to address them. But early on, these can be addressed. Orthodontists are learning this now in their programs, how to recognize these issues and how to treat them. And I can tell you that arch expansion, maxillary arch expansion, orthodontists are doing that early to children, 4 years old, 5 years old, 6 years old, with astounding results. This is life-changing stuff. This is not only being able to breathe, but it's being able to, facial development is improved as a result. The facies associated with an open mouth breather, with a snorer, you all know. And this is an opportunity to screen for this, diagnose it, find out how many there are. I mean, if we could do sampling across our state and get a sense of what the numbers are, then that would help us arrange for treatment for these children. And again, I think it's life-saving. So thank you very much for looking at that. I'll disconnect. Any questions on this before I disconnect?
No, but interestingly, Dr. Greenberg, this
Yes.
is Deb Barr.
Hi.
My little 4.5-year-old granddaughter is scheduled for a TNA June 10th. And largely because she is a 4, and I kept saying to my son and daughter-in-law, her tonsils are way huge. She's not sleeping well at night. So she went to the ENT, and sure enough, and I look forward to better sleep patterns for her, some behavior, possibly improvement, because she's cranky during the day because she's not getting a good night's rest. So, you know, I affirm exactly what you're saying. Her pediatrician didn't think it was a big deal, but it was on my urging that they went to the ENT.
Well, Deb, you are demonstrating something called oral health literacy. You've got it. And we wish that more people had it like you. I know that Helen is working very hard to make that happen in our state, but it's a big job. It's a big job, and we can all help. But gosh, can you imagine how many little kids there are in the inner city and the at-risk populations whose lives are going to be changed in a negative way by not addressing these conditions?
Yeah, I work in schools. I'm a school hygienist, and I see it all the time. All the time. Yeah. Yeah.
Well, I would love to get this in your hands and be able to, you know, and see if you could come up with some screening information for us.
Yeah.
Okay. Well, thank you very much, folks, for listening. I'll stop my share.
Could you send us that slide?
Sure. Send it to
If you send it to
Helen?
us. Yeah,
Helen?
send it to us and we can share it with all the notes. Absolutely.
Okay.
Thank you
That'd
so
be
much.
great.
Ellen, I love stuff like this. I mean, I don't love the condition that Dr. Greenberg described, but this is, you know, and again, and he mentioned oral health literacy. I mean, it's the community, the world does not understand oral health at all. I mean, it really doesn't. You know, it's only teeth and gums, and I don't think we do a great job on our own to communicate the impact that oral health has on so many body systems. And here's a prime example, and this one's right in the mouth, but it's unbelievable. And yet, and that's what my experience at the health department was also. You had to be the prime communicator of how oral health can impact this and that. And when you get an audience and you actually tell them some of the stuff, they're like, you know, sponges. It's just, they didn't know, basically. So it does come down to speaking clearly through some kind of oral health literate messaging that shows the impact that goes beyond just, you know, cavities and gum disease, which is what most people, you know, look at oral health as. And that's a prime example right there.
I think this is something we could also include in our Healthy Teeth, Healthy Children stuff when we're teaching the docs. That maybe we'll have to talk about that and see how we can figure it out, because we have no, I want to say criteria like that, Dr. Greenberg. We have no screening in medicine that will fit in the electronic health record. And
Yes.
that may be something that we can, let's explore and see.
Well, I've been trying, as Helen knows, she's tried to help me to have the state recognize my program. I've shown it to the state health department. They say they don't have the budget for it. They say it's not their responsibility. They just mandate that the exams need to be done. It's been a circular kind of an argument, and I've come up empty every time. And even I know that I believe you have a relationship with the ASTDD, is that it? And they also don't really want to even see my program. I'm disappointed that they don't at least want to see it, because the one that they're using, the BSS system, does not have all of the parameters that I have in mine. I think mine's easier to do, and mine is much more objective than the BSS. And we have all of the components of the BSS included. Tooth decay and missing teeth and all that. It's all in our program. But I kind of a broken record here, I'm sorry. But we have updated it, and now also has a question about commercial bottled water. And I think it was Maryland, if I'm not mistaken, who first showed that children were losing their fluoridated water effect by drinking commercially bottled water. So we need to call the attention to children and their caregivers that that's not a good thing. So, you know, dump out the commercially bottled water if you think it's cool, fill your bottle with tap water and take that to school, because that's what's going to give the benefit that we're, unfortunately, as in Maryland, we're seeing that disappear. I know at Kid Smiles, we treat thousands of kids, and we're seeing cavities are on the rise as the use of cool commercially bottled water is also on the rise.
One other thing we found in Maryland also is that immigrants and refugees who come up here are, you know, because they've had bad experiences with the water in their own countries, won't drink the tap water. And we found that out through an oral health literacy campaign, oddly enough. So that also kind of impedes our efforts to fluoridate and get a lot of people on drinking the tap water, which is mostly fluoridated water in Maryland.
Well, I'm happy to dedicate myself to making this program available to you. If you can find a way to get the state or some other insurance, maybe Delta, maybe DentaQuest, I mean, whoever. I think there's a lot of value in diagnosing children early with some of these conditions. And if we miss it, then we miss a tremendous opportunity. And I can't imagine saying we have a health plan that's good to 2030 and not have this included somewhere, even if it's not my program, some other way of including some of these issues.
Yeah, I think that ties directly with, you know, the size of our program and the capacity of our state program at this point. And I think the more we can advocate for having a larger, more robust program, we then have the capability to do more, have more funds allocated to the work. You know, at this point, you know, we don't have a lot of state funds there. So I think that's a big piece of the advocacy we can do. And sort of, you know, it's a very long, slow road. I will say, anybody who thinks that they can come into this and get work done real quick, it's definitely not that type of process.
They can't hear you.
So.
Oh wait, yes, they can.
So I think that, you know, we really have to look at that as part of our overall advocacy, that the more funding and the more buy-in we get, you know, the more we can do. So definitely a big piece. I did want to speak. I know Kristen had asked a question, Kristen, and I know there was another similar, she asked a question about House Bill 2528, which I pulled up because I actually hadn't seen that yet. But I know there was a similar bill that just stated dentists, it was dentists, optometrists, and podiatrists maybe, that basically, and if I'm reading this right, Kristen, please correct me if I'm not, but I think that it's basically saying that the offices can open against the governor's orders. Is essentially what that bill is trying to accomplish.
Yeah, I wasn't really sure. I had gotten some questions about what the implications were for this, and hadn't heard about it myself, so I also pulled it up and looked at it. And it's not pretty vague. It's a very short kind of thing, but and I wasn't certain if this was the same as something else that we'd already been. You know, is this just the same thing? Like they can open along with the color-coded system and. You know, so I wasn't really certain, but it does look like it could be opening against the governor, you know, fully opening, if interpreted in that way. So I didn't know if anyone here knew anything more about that, or could speak to it at all.
Yeah, and as I mentioned, I know there was one very similar, and I apologize for not having the number off the top of my head, that was very, very similar, specifically for professions, just didn't mention pediatric. I don't know, Kathleen, are you able to unmute? I don't know if you know anything about these from the provider organization standpoint.
I unfortunately don't know anything about the bill. I did just look it up though, and I see that Representative Toohill is the prime sponsor. So I actually have a contact in Toohill's office. So when we get off this call, I was going to reach out to my contact and see if I could get a little bit more information about the bill.
That's great. Yeah. And do you remember offhand what the other one was, or have you guys been tracking? I know there was one that's specific to dentists, optometrists, and podiatrists.
Yeah, I know there's another bill out there. I unfortunately don't know the number off the top of my head. Obviously there's a lot swirling right now, and I just can't keep the numbers in my head, but I can get info on that bill as well to you.
Okay. Yeah. Yeah. I remember reading it. It was somewhere, I think, in the 2400s. But as you can see, that's a lot of bills coming in this session. We've got so much happening. But yeah, that's been, obviously it's been an issue. But Kristen, I'm guessing that that's sort of what that's in regards to, is sort of the putting aside and allowing the waiver from the governor's orders.
Hey, Helen.
Yeah.
Talking about policy, I just got an email from one of our local pediatric practices regarding the state dental forms in grades either K1, 3, 7. And they wanted to know whether the state was going to be giving an extension for families as far as getting those forms back. Now, the state reg says that children may have a dental evaluation that is good for an entire year before the beginning of the next school year, okay? So a bunch of certified school dental hygienists and myself, we meet every week, have been meeting every week. And I said, do you think this is something that we should bring up to the state regarding like a pandemic exception? They're all kind of the opinion that no, we shouldn't, because then that will extend the amount of time that maybe children will not be seen by their dental home. But it's interesting, I just got this email, and I have not heard that the state is extending anything. Have you?
I have not. I think the year, yeah, that year prior will probably cover the 3rd and 7th graders, but I'd be curious. There's a lot of families that K1 visit is the first visit.
Exactly.
So
but on the other hand, you know, for the kids that have a dental home, it really probably is that 1 year time frame is not going to affect them. But we're worried if an extension might be given, and I've not heard that there is going to be one. It's the children who don't have the dental home that are really going to fall through the cracks and are not going to be identified. Personally, I'm not looking at any child's mouth until January. I normally do my dental screenings at the beginning of the school year to kind of have more time to follow up. But I just think with COVID and the uncertainty of even starting school on time and what it's going to look like, I'm not starting till January anyway. But here's my other thing. Why, according to what's out there, Department of Health, et cetera, why can't children be seen for an examination and radiographs? There's nothing saying that they can't be, is there?
Well, not to get to COVID.
Yeah.
But I essentially, again, all providers at this point have to follow DOH guidelines, which say you have to decide if the treatment would result in irreversible harm without being done. So a routine exam, I would not think falls into that category. And do you have proper PPE, and what is the incidence of COVID in your area? Those are the 3 things you have to determine before you give any treatment. So I would say 1, it's probably not the irreversible harm clause. And then 2, I don't want to say that an exam is ever a waste, because we know it's not. And speaking from, you guys all know, like, we're not discounting dental care in any way, shape, or form. But in a situation where we have a statewide crisis of available PPE, I think utilizing PPEs to run routine exams may or may not be the best use.
True, yeah.
I think that would be more the concern. And Dr. Levine did specifically say routine exams and cleanings on the last time she mentioned dental on her press briefing. Mm-hmm. So again, whether it's happening, not happening, every provider has to determine that for each patient.
Right.
So,
thank you.
Can I open my big mouth again, Helen?
Of course.
Thank you. So I'm going to give an interview at 11 o'clock today for Inside Dental Hygiene on the issue of the dental prophylaxis. Is it considered important or not? And if I could just read just quickly from the CDC's latest words on this. The current data suggests person-to-person transmission most commonly happens during close exposure to a person infected with the virus that causes COVID-19, primarily via respiratory droplets produced when the infected person speaks, coughs, or sneezes. Droplets can land in the mouth, nose, or eyes of people who are nearby or possibly be inhaled into the lungs of those with close proximity. So if the droplets are getting into the mouth, which is the biggest of those three, who's the person who is most likely going to help prevent that, get a mouth healthier so that they're more resistant to COVID-19? I think it's the dental hygienist working with the dentist. So I don't see how those visits are non-essential. Those visits are more essential because we have COVID-19 than they were before. Do you buy that?
I buy it. I think PPE is the bigger issue. I truly do. I think,
yeah.
You know, I think that's our bigger issue. And if we get past PPE, then full steam ahead. I think dental offices are very well equipped. You know, they know how to practice infection control for sure. So,
yeah. Yes.
Yeah.
For sure.
Yeah.
Thank you.
So, and I did so. Anything, I wanted to mention around the school forms as well, that we have a student working with us from Temple. We tried a few years back to do some redesign on the dental screening forms that are done within the schools, and it didn't go well. But we're going to try again, because we would like to see that process become, you know, more usable for our state. You know, we get a lot of information from seeing these kids at, you know, K1, 3, and 7, and it would be great to get some more usable information from those forms. So just to let everyone know, that is a sort of a priority area for us this year, and we have a student who's dedicated to working on that over this summer. So that hopefully will change a little bit of policy there. The school health regs have not been addressed around dental for a long time. So that's certainly something that could be brought up, you know, as we move forward, along with school health reimbursement. So many of you are aware schools receive, you know, a set level of funding for their nursing work and the dental screenings. And so that money, or that amount, has not been raised in like 30 years. So school districts really struggle with how to fund, you know, basic health services for these kids. So. And Paula, can I call you out? Because I think you wanted to say something earlier, unless you forgot completely and I'm just calling you out. Oh, you're muted.
There we go. I couldn't figure that out. I just had a thought about the HPV and the vaccine. I just wondered if you talked about having somebody in the office administer it. And I didn't know where you were with that process or how difficult that would be, but my coalition, that tobacco and health coalition that I'm involved with, we tried something similar. I'm wondering too, if you could connect it to the screenings. So there are things that students have to have in order to be allowed to go back to school, and at certain ages. So I wondered if you could connect it. You know, they have to have a dental screening. I don't know what age it is, but maybe tie it with the not only HPV vaccine, but I'll also offer those other DDAP, the ones that are necessary to be allowed to go to school. And I know of an entity that's willing, that they came in and did that for us with the school, not with the dentist. That wasn't part of our piece, but this might make more sense to try to maybe pilot in that way to see if there's traction for that sort of thing, to see if people would actually consider going to the dentist to get their vaccines, and HPV being one of them. You know, sort of pocket it, couch it all in with the other ones that they have to have anyway. I don't know. It was just a thought I had.
It's interesting because it ties very closely with the thought around 7th graders. Well, I mean, even 3rd graders, our older 3rd graders are already eligible for HPV vaccines. So well, I guess it's our really old third graders, because I have a really old third grader who's 9. And so, you know, I think that's a piece of it that could be tied. It would be an interesting idea.
Sort of like one-stop shopping. You don't have to make all these appointments. You have to get these things done anyway. So let's get them done. And then, you know, do some cancer prevention too while we're at it.
Yeah, it's really, really interesting.
Helen, what's the Department of Education's take on having kids having to get HPV? Because again, I'm speaking a couple of years ago in Maryland, the Department of Education was our main problem, basically, because it was too controversial a topic to discuss at all with kids and parents, whatever.
We were able to get at least one school district to really work with us, and the entity that we had that came in and offered the vaccine, again, they offered the DDAP, and I'm blanking on the other ones that they need to have.
MMR.
Yeah, and so it was all offered together. It was recommended, the HPV, but they allowed that entity to help craft a letter and send it out to the parents. But again, it could be something that you can separate from the school district completely, and then when the parent shows up to the dentist's office to get the other, you know, it could be educating them at that point that here's we're offering this too, and it's cancer prevention for your third grader. So
it's interesting, because we've been talking, we know that dentists administering the vaccine is a long ways off. You know what I mean? That's a whole process, but we've really been saying, you know, education around it, and dental offices providing the education can happen anytime. So it would be great to see a tie-in that, you know, when you fill out that school form, did you ask about HPV? You know, like it sort of is that, because if you do it at the third grade level, that's the perfect time to talk to the parents about the importance of the HPV vaccine. And then at the 7th grade level is when you're double checking to make sure they did it. So like sort of having this campaign around, did you ask for dentists, would be really cool. Huh.
Paula, how did you handle follow-up for the second, or in some cases second and third doses of the HPV vaccine?
I believe the entity that helped with it's AmeriHealth, and we also had actually Department of Health assisted too with so they build the insurance companies, but they provide the follow-up. You know, they contacted. We didn't get a lot of traction, and it was the one thing I would say that might be difficult logistically for it to be done this way. We had a day. We offered an event free at the school that any student that wanted to could come and get the vaccines, all of them. So, you know, I think it would be difficult then to have, you know, a dedicated person come. You wouldn't know how, you know, who at what point in time would need it, how many kids are going to be in that office that day. I mean, unless you had the dental office working, saying we're going to offer this day is going to be the day we're doing this.
Yeah, it's really interesting. I think one of the bigger issues we've heard from, I mean, obviously there's a lot of logistical issues with dental offices providing HPV, but I think something else we've heard is because of that broadband access issue and the fact that dental offices a lot of them don't have electronic health records, it's really hard because then your pediatrician doesn't necessarily know that it's been done at a dental office because they aren't integrated. So again, I think that's why this is a much longer term issue. It's not just allowing the dentist to provide the vaccine, it's also figuring out how you're going to make sure that's communicated to the medical side as well. You know, and then we've heard from the AAP, and I know Eve and Kristen both had to step off, so I'll just speak for them here. You know that we had a conversation with the local chapter of the AAP about it, and one of the other concerns was that a lot of that young adolescent, preteen age, the reason that those families bring their kids in for their annual visits, their well child visits, is for the vaccines. So if they get them in a dental office, you might have a situation where they're not going to their physician's office. So again, we have to be mindful of that as well, that we're making sure that we're still advocating for that whole person care too. But education campaign for 3rd and 7th graders. I'm on it now. That's really interesting. We could, and we could work with school hygienists in particular too around some of that. Right, Deb? Yep. Okay. Any other hot policy topics? Anybody have any questions on some of the other stuff? Oh, and I know I see some. Let me see here.
Just as a the coalition, the Crawford Health Improvement Coalition, we are talking about doing a town hall, virtual town hall regarding the status of Pennsylvania insurance. So I'll keep you posted on that. And we spoke about that. We hosted one in Titusville. This one is going to be in virtual. So it might be really nice to have some questions relative to policy you guys are talking about presented to the panel.
Yes, and thank you. Paula was actually the one who got us sort of more involved with the health insurance authority, with the state-based exchange, because I think it was, Paula, your initial event that you were talking about that linked us sort of to the health insurance exchange. And so now we're serving on that work group.
Great.
And that's something, yeah, it's again, connections, we love them. But I think that that's something that one of the things, that we've worked with Achieva on was sort of looking at, we know that on the federal platform for the ACA, that dental for children is an essential health benefit, whereas for adults it's optional. So we thought, and we're still looking into it, but it's more the Insurance Commission and the Department of Insurance we have to work with, is that as Pennsylvania takes over and offers a state-based exchange, is there anything really preventing them from adding dental as an essential health benefit for adults as well? Couldn't we require all the insurances that are on the exchange to at least offer some kind of dental rider as a must-have? So I think that that's a piece of sort of the conversation we've been having. But again, that's not so much with the exchange authority as it is with the Department of Insurance. And so something else we're sort of keeping an eye on. Any other thoughts, concerns?
Yes. Paula, if you could kind of keep me in the loop if you're doing anything with the HPV campaign, because that was a project that I had been working on before. Now, like, everybody's focused on COVID, and I get it, but some things have kind of dropped to the side. So I had reached out, Helen had sent me the HPV coalition groups in my area. I'm in Harrisburg area, 2 of them. So I don't know if they're, I don't know what they're doing right now, if they're doing anything. One of them in York had told me that they weren't doing anything at the time. So anyways, my point being, I'd like to get involved with that. So just kind of,
I'll reach.
You do include me on all your tobacco pieces. Carrie Swain, I work with Carrie, and she was the one that got me connected to you.
And you're on the Crawford Health Improvement Coalition email list?
The one that you send out for all, but yes. I just had a meeting and yes, I'm on that. So thank you.
And I'm wondering, Paula, I know that your coalition is the Crawford County affiliate of the Pennsylvania Immunization Coalition. I wonder if there's one in Donna's area that she could connect with.
Donna, where are you?
Yes, I connected with 2 of them. There was one in work. I was inactive at the time, and Dauphin as well, which I don't know doing anything, and connected me somewhere in West Chambersburg. Can't remember that. Like I said, it's been a little bit that I was in contact with them.
Amy Wishner, I believe, is she's on. I think she's a state level. She's she sends me stuff to share, and she also attended one of our meetings, but she would be the person I would connect you to.
Okay. I'll circle back with her to see what she's doing. So
We are trying to, it's been something that's been dear to us, the Chronic Health Improvement Coalition, HPV awareness. So we're trying to, do another event, maybe another virtual event around it. So it'll be in the emails, but yeah. And any connections we can make with dental too might be a good avenue to take.
Yep. Thank you.
That's I know we've looked at sort of materials too around the HPV, but if anyone has any great sources or wants to share those, feel free to anything. Many of you are on our newsletter list. We do try to send out materials that are relevant to all the work that we do. So if there's anything that we can send out for you to sort of let people know, we're always happy to do that. And materials we have lots of.
Right. No sense in reinventing the wheel if it's something already out there.
Yeah. And that's something I think we even can borrow from, even if you hear of a process or a program in another state. We've been really lucky working with the National Network of Oral Health Coalitions that, if there's something like, hey, does anyone have a really cool flyer for school sealant programs that has a great picture of a sealant? We can send that out, and we usually hear back from, at least a half a dozen states with some good options. And everybody's really, really good about, hey, take it, adapt it, do whatever you need to. So, even our recent, COVID patient guidance document that the Department of Health co-branded, we were able to, we borrowed that from Kansas. Kansas had said, here's the document. And I said, can we edit it? And they said, sure. And now our Department of Health is using it. So I think that that's something that if there's something you're looking for, that is something PCOH can reach out and find some resources about. So.
Yeah, and getting back to what you just mentioned about other states and what they're doing, something that came to mind with Dr. Greenberg when he was talking about prophies. I was just curious how everybody was feeling about a sealant first. Brush the tooth, put a sealant on it, and versus the prophy piece.
If I could comment, I don't think it's effective to put a sealant on a tooth that hasn't been cleaned. So one is much better off doing a prophy first and then doing a sealant. Some studies have done toothbrush prophies before doing sealants. I don't know how good that is, but we want to get some durability out of the sealant, and doing it on a tooth that's covered with biofilm is not going to work.
I was just curious because one of the NOAA presentations, Helen, you're probably familiar with that, was promoting the same-day sealant program.
Well, we have to worry about a revenue-generating device for some, and unfortunately there are agencies who look at that's one of the criteria for a successful program is if you do sealants on certain teeth at certain ages. But they're not really looking at the quality of the sealant. And it's a pet peeve of mine, sorry, but for all of you to know, it's much better on a clean tooth.
Yeah, I'm sure Deb is right there with you too.
And I would say that just as a reminder, we have, so for our state's sealant programs, we do have a manual that was developed on best practices that's for all of the grantees to use. And it does include a requirement for retention checks so that, we're making sure that sealants that are applied as a public health measure within the schools are being checked up on to make sure the right materials and, the provider error. So those random retention checks are really an important part of any, public health sealant program. which is different than individual care that a patient receives in a private practice. You know, and then that's, I think, you know, something that they can be similar, but they're not always. And that's maybe a little bit of a differentiation there too. So, and you know, I don't know, I'm just looking to see, I don't think we have anybody from any of our federally qualified health centers that participate in the school sealant programs on the call, but you know, that's something that we're really looking to grow. You know, we have about 61 schools across the Commonwealth that participate right now, and we'd like to see that number go up significantly over the next 5 years. So school sealant programs are a focus area of the state oral health program. So, okay, so I know we've only got a couple minutes left, so any other questions, comments, concerns, anything that, you know, people would love to run past the group? Okay, guys, I know that you can all reach out to us at any time, of course, and I really do want to thank everybody for taking the time today to join us. I hope that it was a helpful conversation and discussion, and we will look forward to reconvening as we can in the near future, whether it be by video or in person. So thank you all very much.